We're going to get started with our last presentation of the day. I'm glad to see everybody back. This presentation is by Dr. Aileen Brunet, forensic psychiatrist. Don't you always find forensic psychiatrists have also such very interesting stories to tell? She is an assistant professor here in the Department of Psychiatry. She's also the clinical director of the East Coast Forensic Hospital. I've been able to collaborate with Aileen on a couple of cases, and partly that's why I know they're so interesting. She's presenting today on violence risk assessment, a practical guide for mental health clinicians. Thank you.
Okay. Hello. I have mixed feelings about seeing so many people here because I was half hoping many of you would have had the Friday afternoon syndrome and ducked out, and I'd have less faces staring up at me, but I guess I have to deal with it. I forgot that was going to be in there. So I'm going to be talking today about violence risk assessment in the context of mental health clinicians. It's going to be a fairly wide-ranging presentation. I'm not here to teach you how to do a violence risk assessment because to be able to do so would take much longer time than we have. So my goal is to provide some information about the concepts that are relevant, put some things in context for you and make some suggestions about how to think about violence risk assessment, and perhaps also provide you with some specific references of things that you can look at to consider. So ultimately why we're talking about this is, of course, because we deal with people who may or may not be violent in the context of their mental disorder or crisis or situation that they're in, and it is something that people get worried about happening with the patients that they're involved with. And because, of course, as we all know from being subjected to lots of media, that it is a concern. Violence in general is a public concern, but often, depending on what's going on in the media, the issue of violence committed by individuals who may or may not have mental disorders is, of course, also a concern. And these days, even though some risks, particularly in relation to violence, are actually probably decreasing societally, and I'll tell you a little bit about that, our risk tolerance as a society is reducing. So some of you may have been at the Atlantic Provinces Psychiatric Association meeting last June, at which I presented a presentation about violence risk assessment. Some of the content from that is in this, so I'll be warning you that you may see some repetition. But as we proceed, and before we get started, I want you to take a look at the questions on the slide and think for yourselves what you consider the answers that to be, and how these questions might influence your practice. And we're going to go through and sort of informally address some of them. So I want to talk a little bit about the issue of base rates of violence, sort of what are we talking about when we talk about violence, how common is violence, look at sort of the general population and the mentally disordered population, and also issues related to concepts about violence risk assessment, risk factors, what sort of the differences are between looking at imminent, short, and long-term risk prediction, some potential tools to use or consider or be informed about when you're looking at violence risk assessment, and also how some of those tools can inform risk management. Because ultimately, it's not particularly useful to necessarily be able to predict whether something will or will not happen without also being able to consider what can we do about it. Okay, so further questions in relation to the previous ones I want to ask you to think about. I want to ask you to think about, from your own perspective, do you think violent crime is increasing? This is a relevant subject. Are individuals with mental illness more likely to be violent than those without? And if I told you that someone with a mental illness who had previously been violent was at high risk of future violence, what does that mean to you? What's your automatic thought about what that means? What conclusion do you come to from that? So before we can talk about predicting violence and what the risk is of someone potentially being violent in the future, we have to actually think about what the base rate of violence is. So how frequent is violence? Because the ability to actually predict something happening is very much tied to how common it is. So is it a needle in the haystack and we're trying to find out which straw is a needle, or are there dozens of needles in the haystack? How hard or easy it is to find the thing that you're looking for or to predict whether or not it's there. So I'm going to talk a little bit about base rates. And the definition of a base rate is basically the number of times an event actually occurs relative to the population. So the number of murders that occur relative to the population. The number of suicides that occur relative to the population. For both of these, they're reported as the X number per 100,000 population, for example. And it could be the same thing for cases of cancer, number of people with high school diploma per 100,000, et cetera. So that's base rate. Base rates, as I alluded to earlier, are really relevant to the issue of prediction. So again, if something's very, very common, it can be potentially easier to predict. If it's very, very uncommon, it can be difficult to predict if it's a rare event. And the other complication with regards to looking at base rates and violence prediction is that human beings are very prone to what they call the base rate fallacy, which is essentially ignoring the base rate, ignoring the statistical information available because for whatever idiosyncratic reason, excuse me, I've had a cold, you think it's not relevant. So for example, if we think about the fact that teenage boys are at higher risk of getting in motor vehicle accidents, insurance companies know this, that's why they charge a lot. But if you think my 17-year-old is very responsible and he would never text while driving, so he's not at risk, you're perpetuating the base rate fallacy because you're making assumptions about something that is relevant to that person that's not actually relevant to his risk. So with respect to the issue of violence risk, another example of the base rate fallacy or potential one, depending on what your understanding is if you have two individuals with mental illness who've both been violent, one committed a minor assault against their neighbor, another killed their neighbor in a brutal and horrific manner. Everything about them otherwise is equal. Their diagnosis, their age, their gender, everything is the same. If I say to you, who's at higher risk of future violence, how many people would say it's patient CD? Nobody puts their hand up. So most people would say the person who committed the worst crime is at higher risk of violence. But that is in fact incorrect from a statistical perspective. But the fact of that horrible offense causes people to think, therefore they must be at risk of being more violent in future. But from a base rate and statistical perspective, it would be incorrect, but that's the way we think. So is violent crime increasing? The answer is no. There's a lot of data on this slide. I'm not necessarily going to read all of it, but the bottom line is this statistical trend now having occurred over decades is that violent crime, all types of violent crime, have been decreasing for quite a while. Many people don't believe that, and when I tell people, they often get a bit worked up and say, but what about this, and what about this? And in advance of people possibly lining up with the microphones at the end and asking me questions, all I can say is that this data has been collected by Statistics Canada, data that's been reported by police since the 60s, and also by the FBI. It's all completely been validated and widely accepted that, at least in Canada and the United States, violence has been decreasing for quite a while. But most people don't believe that. Most people think that violence is rampant and the world is very, very unsafe, when in fact, it's safer than when I was a teenager. Interestingly, Nova Scotia has a relatively high violence and homicide rate compared to other parts of the country, for whatever reason. So just a bit of further data to put this in perspective with regards to the decrease in violence that has occurred over the past several decades. And a further slide showing what's called the Violent Crime Severity Index. That's the light blue line. That is a sort of proportional measure that is done by the police regarding how severe a violent crime is. It's, in this slide, calculated relative to the year 2006, which is to be 100, whatever that measurement actually means. And you can see that there was a gradual decline from 99, a bit of a rise in the mid-2000s, and then an ongoing, relatively steep decline since then, not just in violent crime severity, but all crime. And just for a little bit of comparisons of what the homicide rate is in various countries, in case you're interested in it for vacation planning, I recommend Denmark, because they have probably the lowest homicide rate in the world. Honduras, as of last year, had the highest homicide rate in the world. And so ours is 1.6, so that's 1.6 homicides per 100,000 in the population. And interestingly, for about the past 50 years, murder rates in the Americas have been higher than Europe and Asia by a factor of 5 to 8. So just a little bit of comparisons, because what we do, we're also worried very often about our patients killing themselves. And sometimes, though, in mental health, we're more comfortable with the idea of people being suicidal and at high risk of suicide. I've seen medical records that say chronic high risk of suicide and someone's discharged. We have a reasonable tolerance for that, and we accept that. Whereas our tolerance around concerns about people being violent can sometimes be less so. But it's interesting to see that, in fact, the suicide rate, something that we're comfortable working with clinically, is about 6 times the rate of the worst type of violent outcome, which in a way is sort of equivalent to suicide, which would be homicide. And interestingly as well, the rate of suicide since about the 1920s has not really changed significantly. It's done a bit of this, but it hasn't actually statistically significantly changed in comparison to the violent crime rate, which, as I showed you, has been decreasing significantly for many years. And also interestingly, even though suicide is a much more common occurrence relative than, say, the worst violence outcome of homicide, there aren't any validated predictive tools for suicide risk in terms of being demonstrated to show that it actually predicts who's at risk of killing themselves. Well, whereas there are a number of tools that are validated for use of predicting violence, not homicidal violence, but violence. Okay, so back to some of the questions from the quick quiz at the beginning. Are individuals with mental illnesses more likely to be violent than those without? If yes, by how much? So the general consensus of the public opinion would say yes, for sure. And that is probably related to a number of factors, but certainly concern, fear, and worry about violence in the mentally ill has probably been with us for as long as people have been seeing people who are different and appear to be disturbed, and maybe partly an innate human concern about other. But even in this time of us trying to work on improving stigma, or reducing stigma, and improving acceptance of people with mental illness, there still is this underlying strong concern that people have about the relationship between mental illness, particularly schizophrenia and violence. So, although people feel very strongly about it, the other side of it is there actually is an element of truth to that it's important for us in working with individuals with mental disorder to acknowledge. It's not to the extent that people in the general public might feel that there's a concern, but it's been shown from an empirical perspective that there is definitely a relationship between mental disorder and people being at increased risk of being violent, likely directly as a result. The influence of substance abuse is much more substantial in causing people to be violent than mental disorder in terms of major mental illness itself. From one of the most widely quoted studies from the 90s related to the ECA study looked at 10,000 people in primarily, I think, urban environments in the United States, and looked at how many people had been violent over the previous year, and they did police records, direct interviews, getting information from collateral informants. It was very in-depth. They found that in the previous year, 2% of the non-mentally ill, non-substance abusing population had been violent. And the interesting thing is that this is a time when violence was quite high in society in the early 90s, right? Higher than it is now, so 2%. In people with mental illnesses, without substance abuse, 7% had been violent in the previous year. And with overall, it was 12%. And individuals who had substance use difficulties was called other substance use, which was non-alcohol and non-cannabis, I think. 32% of them had been violent in the previous year. So the calculated from this study and others adjusted relative risk of an individual being violent who has a major mental illness alone is 3 to 1. So at about 3 times the rate of people without major mental illness. Lifetime violence rates from other studies suggest that individuals without major mental illness have a 15% lifetime violence rate. Major mental illness, 33% lifetime violence rate. Major mental illness plus substance abuse, 55% violence rate. So some studies have said that the population attributable risk of violence in the community due to mental disorder is felt to be about 3%. What that means is if we could cure, eliminate, control, perfectly treat every mental illness, major mental illness, not substance use or personality disorder, we would be able to get rid of 3% of the violence in the community. This is American data. And the relationship between major mental illness and violence has been demonstrated in other locations and settings. Schizophrenia spectrum disorders from a violence risk perspective are felt to be probably the mental disorder or condition that is most risky on a population basis, not necessarily on a day-to-day or individual basis, but as a group. And those disorders increase an individual's risk of being violent relative to someone without those disorders at the numbers that are there. And when you look at the early psychosis, first episode psychosis population, or risk of somebody with a mental illness versus somebody without a mental illness committing homicide, the risk is further elevated. So I can't actually tell you the exact amount, but what that data shows is that people with schizophrenia are at greater risk of committing homicide than the average person. Statistically significantly greater risk, but still infinitesimal if you think about the fact that, for example, in 2012, there were about 540 murders in Canada and 35 million people. So that is the perspective as well when we're looking at how easy is it to predict the worst possible outcome when you have 35 million people and 550 of them might be at risk. So numbers in terms of the lifetime violence risk are fairly similar for bipolar, except for the points I made at the end. Other mental disorders sort of statistically associated with violence include traumatic brain injury, personality disorder, learning or intellectual disabilities, and depression. The mental disorder conditions, considering it broadly, that are most at risk of causing violence are substance use conditions and antisocial personality disorder. And based on some of the epidemiological evidence that has been reviewed or studies, the population attributable risks to those conditions, psychoses, personality disorder, and alcohol and substance disorders are as listed there. So 20 to 25% of violence is felt to be related primarily to alcohol and substance use disorders in the absence of other conditions. Yes, Stephen?
Are you including drunk driving, people killed by drunk driving as a violent event?
I cannot speak to that. One of the issues, and I was thinking in the back of my mind that I should mention, is how violence is defined is very variable depending on the study. My recollection of reading that was not, but I can't say for sure. So that is connects to a relevant point, which is what is violence. So some studies and some research tools or clinical tools that look at predicting violence will consider being loud and what people might call aggressive or throwing things or destroying things to be violence, whereas others narrowly attribute or only call violence where there's someone's harmed. So either, an actual physical altercation, whether threats are considered violence or not might be variable depending on the tool as well. So in terms of people with mental illness, what's the rates of violence in different settings? Again, from the epidemiological catchment area and further work done by the MacArthur Foundation, which does a lot of work looking at violence and major mental illness in the population. You can see the numbers there, which I would guess probably correspond to people's clinical experience in terms of where, when patients are being encountered, that violence might be seen, that those numbers make reasonable sense to me. That data also suggests that in the absence of substance abuse, a history of personal violent victimization, and a neighborhood where violence is part of the culture, the risk of people with mental illness being violent can be significantly reduced. And that's relevant because individuals with mental illness who are violent, many of the factors that contribute to their risk are the factors that contribute to the risk of anybody being violent. It's not solely the illness, it's other background factors such as being male, such as being young, such as having a low socioeconomic status. So some of the risk is potentially mitigatable depending on the environment in which the person is in and the life that they've experienced. So if I tell you a mentally ill person with a previous violence was at high risk of future violence, what does that mean to you? Does it mean they're at a high likelihood of being violent in any way? That it's a high likelihood that the violence will be serious, or both? Probably a lot of people think that they're at a very high likelihood, like say approaching 100% or 75% of being violent, then it's likely to be a serious violence. But that in fact is not the case. And that's because, again, of the base rate issue. What is the most common form of violence? It's common assault, in which there's actually no harm done to the victim. As you can see, common assault is about 300 times more common than murder. So we worry about very serious violence, but when we're doing violence risk predictions, especially with regards to long-term risk prediction, what we're actually looking at is what is possibly going to be the most likely outcome or most common, which is common assault, in which no one is actually hurt. So the risk assessment looks at a risk of future violence in those who've already been previously violent as a general or specific likelihood depending on the tool, but it can't look at the nature or timing of the violence. And how successful it is going to be will be dependent on the base rate. Okay, so a brief history of violence prediction by clinicians. I was going to provide you with all sorts of very interesting information at this point, but I decided that I would be very concise and say that's it. History has shown we're not good at it. So clinicians are really reasonably good at predicting violence in the short term, sort of what's called imminent, hours to a week, based on what they're seeing in front of them. But in terms of longer out than that, clinicians operating under their own expertise and what they think are not very good at it. And that's interesting to contemplate because that's what people are doing when, for example, they're suggesting people might need to be on a community treatment order or might need to be detained in hospital in a voluntary status because they're a risk to others due to their mental disorder. What you're engaging in when you're doing that is essentially a longer-term violence risk prediction, and in which is something that actually it's been shown that we are not very good at. And there's a number of reasons there as to why we're actually not very good at it. So this is another quick quiz to maybe get you thinking about some of these issues. Thank you. Excuse me. Okay. So the Violence Risk Appraisal Guide is a violence risk prediction tool developed in Canada that takes an actuarial approach. There's 12 items The person doing the risk prediction is meant to score them according to what the Violence Risk Appraisal Guide tells you to do. So lived with biological parents until you were 16. If the answer is yes, you get a score of 0. That's what the scale says. If the answer is no, you get a score of 3. Essentially, the scale weights the items based on statistics for you. So you don't have to do anything other than collect the information and ask the questions. So the top score is 38, which results in a violence prediction risk of 100% likelihood of being violent over 7 and then 10 years. So I want you to look at those and tell me which single item on there you think contributes most to a person's long-term risk. And then tell me what after that, what's the one that contributes second most. And then there's some items on there that are inversely related to violence risk. So I'm not going to give it away, but I'll tell you that marital status is not. So, for example, if you've never been married, you're at higher risk of being violent than someone who has been. But if it was an inverse relationship, it would be if you've been married, you're at higher risk. So there's certain items in there where it's an inverse relationship. So I'll let you think about that for a second, and then we'll go to the next slide. So the one in red, the PCLR score, which is the extent to which someone is psychopathic, contributes the most amount of score if it's maxed out to an individual's violence risk. You can get 12 out of 38. And these are all mentally disordered individuals who've been violent before. Next after that, it's elementary school maladjustment. So the next most strongest in terms of the weighting of points towards risk of future violence out of all those items is elementary school maladjustment. The ones that are inversely related are age of index offense. The younger you were at your violence, the more likely you are to be violent in future. The lesser injury experienced by your victim, the higher risk you are of being violent in the future. If you've had any female victim of violence ever, the lower your risk of being violent in the future. And if in this scale, VRAG, if you had a diagnosis of schizophrenia, you were at lower risk of violence in future, which is contrary to some of the epidemiological data that I've told you about, which has been repeated internationally. So I'm not sure exactly how that works, but that is what came out from the development population for this one. So I'm going to tell you a little bit about different types of risk assessment. And then we'll talk a bit about a couple of risk assessments. So the type of risk assessments that most of us do, if you're not a forensic clinician, is what we call unstructured clinical, which is you use your experience and your expertise and all the patients you've seen and what the person is like in front of you, and you come up with an opinion of what the likelihood of this person being violent is. And that's what we're comfortable doing. That's how we all work. That's what we do in most of what we do. What's the likelihood that they're going to stop taking their medication? What's the likelihood they're not going to be successful in their community placement, suicide risk, or further self-harm, etc. The problem is that this is not a very scientific approach. We're not able to be scientific in doing it independently. It tends to be, we will say, oh, high or low or never or always. The fear of being wrong influences our opinions, and it's not reproducible. So I can see someone have an opinion, someone else will see them have a different opinion. 5 days later, I'll see someone who might be very similar, and for whatever reason, idiosyncratic reasons, I'll have another opinion. So this is what we tend to do generally in practice, but which research shows is not very successful. Actuarial approaches use essentially statistics through research that's been generated that looks at the statistical relationship between factors and the outcome, which is violence. And it produces a purely actuarial instrument, just like how the insurance companies decide what your insurance rate is for driving. They look at how old you are, what your gender is, whether you've taken defensive driving courses, which apparently make you at higher risk of having an accident, defensive driving courses, I've learned recently. And then they put in a little calculation, and then they say, this is how much you pay, which is essentially, this is your risk. So that's what the VRAG does. So it has very good predictive power, and it's very useful for establishing person's long-term base rate of violence, because it's over the long term, but it tends to be vulnerable to the issue that it's immutable. Nothing you can do can change the number that this risk prediction instrument generates for you. So from a treatment perspective, you can't change what that scale says. So the other form of risk assessment that is widely practiced now in forensic psychiatry anyway is what they call structured professional judgment, which is using risk assessment tools that combine static factors, so historical variables like elementary school maladjustment, whether you had a female victim, et cetera, with dynamic factors, clinical factors, changeable factors, contextual factors. That doesn't give you a specific score or risk level, but it gives you a general risk range. Is it low, moderate, or high? So it's not actuarial in that pure sense, but it has empirical basis. So those are some examples at the bottom there. The HCR20 is the Historical Clinical Risk Scale, which is developed in Canada and used internationally. The SARA is a spousal assault risk assessment, and the third one is a sexual violence risk. So a structured professional judgment tool includes known risk factors that are linked to violence, and it is essentially an aide-memoire. It forces you to think about these that are known to be related to violence and to rate, are they present, not present, or partially present. It's sort of like suicide risk assessment checklists that make you think about factors that are known to increase an individual's risk, so that we're not just relying on ourselves or people in the front line to be able to generate those in their mind. So it allows for consideration of case-specific factors that may influence the ultimate score, and it provides for means of intervention. So that was the Violence Risk Appraisal Guide. Again, those are the factors, just showing you a little bit about how the scores go into categories, and this is the range of types of risk of violence that are generated by it. This is a tool that's not necessarily used clinically in the emerge or in community or in inpatient units, except in the forensic context normally, to essentially establish what a baseline level of risk is. So looking at someone who's in category 9, or what they call bin 9 versus bin 4, is a different individual who you may have to try and manage and deal with differently, for example. So the HCR20, which is a structured professional judgment instrument, is used in all sorts of contexts in mental health, outpatient mental health, inpatient mental health, long stay, and in forensic, because it's very intuitive and is not just meant for forensic patients, and it's very useful to use. And you'll note as I proceed to a couple slides that a number of the dynamic factors that are included in the HCR20 actually would fall within some of the Camberwell items. So they can match on to items on the Camberwell assessment of need, which is commonly being used in mental health, and therefore can sort of capture and reflect those things which we're already trying to address already. So for the HCR20, all these factors in terms of a history of problems with these issues are felt to contribute to an individual's longer-term future risk of violence. That sort of provides a sort of base. But then the clinical items relate to the recent or current perspective. What's the level of insight the person has? Are they currently having any violent ideation or intent? What are their symptoms of their mental disorder? Is their current affective, behavioral, or cognitive instability? And what's their current treatment or supervision response? These are things that are changeable, things that we can intervene on, and things that we can reassess over time. The risk management perspective or factors sorting looks at what is possibly going to happen in the future, depending on where the person is going or what they're planning for. So are there potential problems that could be foreseen with these items, which are things that we all would generally consider anyway from the perspective of, say, an inpatient planning to discharge them, or somebody who's out in the community where you're trying to develop a plan for them. So putting all those together, again, sorry, I'm pressing the wrong buttons. The risk assessment instrument, which comes in a little booklet, is very handy, very written in a very common sense way, not overly technical, very useful. Guides you to consider these things and then flow from there to develop a plan. So just a little comment about the issue of predicting violence in those who've never previously been violent. It essentially is not something that can be achieved from a risk prediction perspective in terms of an instrument or hints or tips. Be able to predict the first incident of violence is difficult. There are certainly demographic factors that might contribute to it, but otherwise it's not really a predictable entity. Almost all violence risk prediction instruments, particularly ones that look at the long term, are predicting violent reoffending or repeat violence, recurrence of violence in someone who's already been violent. Now that initial violence could have just been an assault, common assault. It doesn't have to have been severe. It could have been just punching somebody without any injury or uttering a threat. That can then initiate a risk assessment of future violence, but until something like that happens, it's difficult to predict who might be violent the first time. From a demographic perspective, though, if you look at individuals, the young, the male, lower IQ, lower socioeconomic status, cluster B personality traits, history of early trauma and early behavior problems, lower level of educational attainment, substance abuse, and employment and residential instability are demographic factors known to be associated with violence in general. There is research that looks at predicting violence and linking it to clinical symptoms. And there's a lot of research out there and a lot of symptoms that have been considered to possibly be higher risk clinical symptoms. So, for example, persecutory delusions and what are called the sort of threat override control symptoms, in which individuals feel that they have no control of their thoughts or actions or behavior from a psychotic sense. Delusional jealousy, delusional misidentification, these have all been psychotic symptoms felt clinically to be related to risk of violence. But if you look at violence risk prediction instruments, none of them identify specific symptoms. So while clinically these may be felt to be relevant, and they may be particularly relevant for an individual person, on a population to statistical level, they've not panned out. What has been demonstrated, though, that anger and negative emotions associated with delusional beliefs or associated with hallucinations, particularly command ones, could be the link. Because we've all seen people who have had those symptoms. Persecutory delusions are very, very common in population of individuals who suffer from psychosis, but not everybody who has a persecutory delusion or a command hallucination has been or is going to be violent. Some suggest that anger related to those symptoms may be part of the impetus that could increase the risk. From an acute imminent perspective, factors that have been identified as indicative of imminent violence, so within an hour, within a few days, are things that are listed there, which I think for people who work in emerge, on short stay, or in even longer term units are very familiar with and are attuned to when you're on the front lines. And these factors, plus some others, are captured by instruments that try to predict the likelihood of imminent violence in individuals. So a blurb at the end, one of the things we often get asked in forensics is a patient team wants to discharge a patient, but they're concerned about their risk of violence because of things they've said or what they were saying before they were admitted. There's a lot of uncertainty. Should we actually let this person out? And looking at violence risk prediction in people who are about to be discharged, the literature suggests that the post-discharge period is a time where violence risk is elevated, just as it is with suicide. But there's not been any good development of specific instruments to look at that. The advice would be to look at the person's long-term risk and the current clinical factors. There was an instrument developed in the United States called the Classification of Violence Risk tool, which is sort of a decision-making tree, but it's a computer program that you have to buy and plug in the answers that apparently gives fairly good predictive likelihoods of violence risk in the next 2 weeks or a month, I think. But there doesn't seem to have been a lot of research on it to validate it. So I cannot recommend it, but it is out there if you go looking for how do I predict if my discharged patient is going to be violent. So looking at inpatient aggression and predicting that and considering that, which is a different thing than predicting someone's likelihood of being violent over the long term. One of the things that's worth looking at is the types of aggression that have been categorized on the inpatient. And then there's different sort of categories that have been given, but the general concepts relate to violence that is impulsive. So in response to immediate provocation with agitation, loss of control, and psychiatric symptoms concurrently, which is the most common form of violence in inpatient units, but probably the least predictable. Organized violence is violence that may be premeditated, but is meant to serve a particular purpose by the individual, not necessarily symptom-driven, but possibly. And then purely psychotic violence, which is a mixture of symptoms plus impulsivity and negative affect. Okay. So I'm going to whiz through to the end. So one of the things that I wanted to emphasize in this talk is to suggest to people to consider including an assessment of patient's violence as a routine part of taking a history. Because often, my question at the beginning that was on the list of questions, do you do anything beyond asking if the person's having thoughts of hurting someone else as part of your violence risk assessment? Often people say, no, really, I only ask them that and then I stop. From my perspective, it's worth looking at someone's violence risk the same way you would look at assessing their suicidal risk, which is what is their history of having been violent, similarly to what's their history of self-harm, or how long have they been suicidal, what's the context, what was their mental state at the time, were they under the influence. Taking into account these factors and getting a history will help you with managing the situation in the future. And if knowing now what some of the known historical factors are that contribute to an individual's risk, that gives you a sense of the baseline and where that person falls. So very quickly, in terms of inpatient violence, research suggests that certain things such as age, gender, and race are not necessarily relevant to inpatient violence. It's not consistent in studies. Major mental illness, probably the most prominent, but of course other symptoms, as well as lack of insight is a factor related to inpatient violence often, and length of stay, more violence with longer stays, interestingly. With regards to staffing, because violence is just not about what the patient is doing, but the environment that they're in and how people are interacting, there's not consistent data on the age of staff, so younger versus older frontline staff, more or less female or male staff, for example, what their level of experience is. There's studies that suggest it may be relevant and studies that suggest it's not. What some studies suggest is the style of staff and how satisfied they are with their jobs may be relevant, because an authoritarian controlling approach is probably not an approach that is going to minimize violence on the units or potential provocative situations. The whole situation about patient ratios and mix and bed occupancy from the literature is not clear. So that, I think, captures some of the other elements. Most of this literature is very much done in certain specific locations, and as you can imagine, different units, different places are widely different. So it's hard to come up with a consensus. So very quickly, I may go over a minute, Kurt. One tool that seems to be well and widely used and well validated is called the Brunet. It's supposed to have a little line through the O. I couldn't figure out how to do that, make it look nice and Scandinavian. So the BVC was developed in a maximum security unit, but has been validated in other settings. It's for predicting imminent violence in an inpatient unit. It has essentially what is high false positive rate and may be more powerful at detecting people who are not going to be violent. So they just took 6 common behaviors found to be most common during a 24-hour period prior to someone being violent within the next 72 hours. And those are all probably fairly common and commonsensical. Depending on the score, you either score a 0 or a 1. If you get a score of 2, it has a relatively high for this purpose of high accuracy in predicting that violence will occur within the next 24 or 72 hours. But if it's below a 2, that's probably not written exactly clearly, it has a very high specificity of predicting that violence will not occur. Part of the problems with scales or tools that predict imminent violence is if you fill out a tool, you're forced to look at these things and you say, oh, that score is high, you're going to do something. Very few places will put in a scoring system and then have you stand by and watch and see what happens. So most of these tools are developed retrospectively, and then they're implemented, and then people act. So it can look like there's a high false positive rate because the person ended up not being violent even though they had a high score, but that's presumably because something was done in the intervening time. I'm going to skip that. Just going to put on very quickly the imminent risk rating scale, which is developed at the Forensic Hospital by one of our psychologists, and I think is being used in a couple settings locally. It captures a combination of factors that include both how the person is presenting and contextual factors, because it's felt that it's not just how the person is presenting, but a little bit of who they are and what their past history of violence is, and what their situation is. So it, again, has a reasonable predictive ability for violence with up to the next 7 days. But the way this scale works, it potentially is better at saying these people are not going to be violent versus these people are going to be, for sure, going to be violent. Because, again, of the high false positive rate, and that it's probably easier to predict people who are not going to be violent than violent. Okay, that's the end. That's a bit of humor for the end of the day. That's my son in his combination Maple Leaf, Lord of the Rings, and Bonhomme from Carnival costume. I've sent it to a few people, and they think he's at risk of something in future, but I'm not so sure what. So I'll take some questions. Thank you.
I have a couple of unrelated questions. In other words, the two are not related. One of them is that you pointed out that young males are risk on their own. Excuse me. When you looked at the decreasing rates of violence over... I should have had a glass of water. So when you took a look at the risk of violence in young males, and you showed the decrease over a period of time, over a number of years, was that also in any way parallel to the number of males in the population at that time, say between the ages of 18 and 40 or something like that? Because if you have a decrease in the number of males in that age group for demographic reasons, you're going to see that same line. So I'm just not quite sure whether that was part of the factor.
So that line was in reference to adults, so 19 and over. There is a similar
19.
line for youth over time. So youth violence and youth crime is not at such a steep slope, but also has been decreasing over decades. So I can't say whether they compared how many youth there were per 100,000 in the 80s compared to how many there are now, but looking at number of reported violent and general crimes by youth, it's the same shape. I don't know if that exactly gets at your question. I haven't seen anything that looked at it.
It kind of does, because then you're saying looking at the rates of violence in youth as opposed to the general population. And that's the issue, because of the demographics tend to show increasing aging of the population.
Right.
So you could say you've got more people, and therefore the number of people in the younger age group is going to decrease relative to the population. Therefore, you're going to see a decrease in your statistics because they're the people who do it.
Right. So the rates that look at violent youth are looking at per 100,000 youth.
All right, that makes more
And it
sense.
is decreasing.
Yeah.
But what is interesting, and that's not really captured there, is the whole issue of violence in the elderly and the older groups, and concerns related to, say, long-term care and nursing home placements, where violence is a significant issue, potentially increasing, but for which there's not very good demographics or data.
Okay. The second question, and no doubt relates to my interest always in children and youth. You pointed out looking at some past features, child abuse, child maladjustment in school, low educational achievement, etc. How frequently is that factor found when you are evaluating this particular population?
This particular population being which population?
The populations that you're using these scales on to assess, that include questions about childhood achievement, childhood adjustment, educational achievement, etc., abuse. Some of the questionnaires clearly have that as part of it, and I'm
Right.
wondering how frequently is that positive for the populations that you're working with?
I cannot answer that question directly. I can tell you for the development of the VREG, they used dozens and dozens of data points of what they had and in terms of information about people. And then when they looked at the people in the future who became violent, they looked at which of these data points were statistically related to future violence in people who'd already been violent once. And the ones that I showed you in the list of 12 were the ones that came out, that were statistically significantly related. There's no explanation or no theory. There's no why. It just is and was. For the HCR20, which isn't an actuarial instrument that doesn't tell you, how important childhood maltreatment is, all the factors in that instrument are what we would call sort of empirically related. So lots of writing in the literature saying people who've had early trauma or been exposed to violence or have a history of substance use are at higher risk of violence. And then that's how they generated their list, from basically a review of the literature and how often different factors show up and across different contexts and circumstances. So they put that together. So there's no specifics of, in the population of origin, this is how often those are shown, but that across studies and countries, those factors have been shown to be contributory. And for the HCR20, that list of historical factors has been validated in probably at least a dozen countries. It's an internationally used instrument as being a valid risk prediction instrument.
I think the purpose behind my question, in a sense, is if that's a fairly common factor, it points out a reason to give more attention to what's happening with children in our society.
Yeah.
Because if we can reduce that kind of factor, then we're saving something in adulthood. And we know from looking at the Adverse Childhood Experiences study, where there's the 10 different factors that are looked at there, they're cumulative.
Yes.
And the more you have of those, the more you are at risk of substance abuse and alcohol and various types of serious problems in adulthood.
Yeah.
So there's a connection.
And I agree, and I think that type of data should inform public policy and practice, right?
Yeah.
Such as should the decrease in crime, but depending on the government of the day, it doesn't necessarily. Right.
Yes. Logic is a different issue. Thank you.
Thank you. Is a forensic person going to ask me a question? Chantal?
I have a question. I'm gonna finish off with a question. Aileen, I found particularly interesting the issue with regard to those of us who work in the emergency room and are doing assessments, and we generally wouldn't be using any of the tools, but rather just our clinical interview, and the idea of asking around rather just, do you have any thoughts of harming someone else, about have you ever harmed anybody else in the future? So I guess maybe further to that, do you feel like we, and particularly in light of the fact that the risks associated with a serious violence is quite a bit lower than risks of suicide. Should we be doing something different in the way that we're doing assessments around violent risk in the emergency room with our patients?
Well, I guess my comment about whether doing something different touches on what is actually being done, right? So suicide is more common, but there isn't really any good way to predict it at this time. There are better ways to be informed about an individual's violence risk than probably what we're already using. So I think being mindful of what a person's violence history is and to what extent known demographic factors that are associated with future violence are present, I think is useful for your own clinical opinion to give it a general sense, and then looking at the person in terms of what the context has been. So I don't think, and I'm not in the emerge, so, and I don't generally have a lot of, at our site, for whatever reason, we don't have a lot of self-harm or suicide risk issues, so our focus is not on that, so I don't do that in an active clinical sense. But I would think some of the attention, the way attention is paid to suicide risk, you could easily flip it around and do it with violence as well. Does that make sense?
Yes.
Can I just ask you if there's any evidence to suggest that providing individuals with anger management strategies is helpful in reducing the likelihood of future violence?
I would say that some studies for the population that was studied, yes. On a broader scale, I don't think anything's been done comprehensively like how there has been for psychological treatments for, say, depression. If you're looking at CBT or interpersonal therapy or other cognitive psychological interventions for mental disorders, probably there's nothing at an evidence-based effectiveness level at that level. But well done cognitive behaviorally oriented anger management would probably be effective for certain types of individuals who could benefit from it. But it also tends to not be very available. I don't know if you found that, but we have found that at the Forensic Hospital for community-based anger management. It's not very available. But it probably does work for some. It's a matching issue.
Maybe I could just make a comment. The vast majority, is it on? The vast majority of suicides are preceded or, attached to mental illness, right? But a minority of homicides are attached to mental illness.
Yes.
So our approach is going to need to be a little different.